Friends, in this video we are going to see Subtenon block, the magic of Phenocaine, and use of a Prechopper designed by me, known as Mohanta's Prechopper. This is a nick in the conjunctiva in the inferonasal quadrant. Then I hold the tenons and make another nick in the tenons capsule, expose the sclera and take a curved cannula that goes through this opening posteriorly, and then I inject lignocaine about 1 milliliter, 1 ml, and anesthesia becomes very good, and it's a very safe technique. Though there can be some subconjunctival hemorrhage, the technique is very safe. And now you see the pupil is not dilated at all because the patient is allergic to a lot of eye drops, and we thought that we will not put drops, we will use only intracameral agents. We will use intracameral Phenocaine preparation, which contains lignocaine, tropicamide and phenylephrine. So this is the main incision. It's at a posterior aspect of the limbus at around 10 o'clock. And now see the magic of tropicamide and phenylephrine. This preparation is from Entod. It contains lignocaine also. And just see, after injecting just a little small bit, starts dilating. I inject another bit on the other side, and in few seconds the pupil dilates completely, full dilatation almost. And now the antechamber is filled up with HPMC. There is some bleeding from the main incision site. Probably the patient is having blood pressure on the higher side because of lot of stress. And this is a side port about 3 clock hours away from the main wound on the left side. And now I am going to do Capsulorhexis. Make a small nick at the center, raise a tag and guide this tag anti-clockwise. And complete the rhexis. Size of this rhexis is about 5 mm. We can see that cataract is soft. It is grade 2 nucleus sclerosis, or maybe between grade 2 and grade 3. We can do direct job, but to reduce the amount of ultrasound, the amount of ultrasonic energy, we can divide the nucleus manually by a Prechopper or nucleus cutter and a nucleus sustainer. The nucleus sustainer goes inferiorly, hooks the equator and supports, while the Prechopper goes straight towards it and cuts the nucleus into pieces. So we have got 4 pieces by this time in a very short time, maybe in less than 1 minute. And now the antechamber is filled up again with visco, and then take the handpiece and go into the anterior chamber. the handpiece goes with its bevel down, some superficial lens matter is removed, and the pieces are separated nicely using some vacuum. Just hold it and separate it nicely, and then each nuclear piece is emulsified. Ultrasonic energy used is 50%, flow rate is 48 ml, vacuum is 480 millimeter of mercury. Now this is the last piece, and it gets emulsified in no time. And now I am trying to remove some cortex by the handpiece itself, and I find that all the cortex is removed by the handpiece. Please don't try this. This also has a learning curve. If you want to learn this, be ready to to rupture or tear one or two cases. The posterior capsule is, you're going to catch the posterior capsule and but once you learn this, it reduces the surgery time dramatically. There was chemosis. I made some incisions in the conjunctiva and reduced the chemosis. I take two buds and press the conjunctiva, and most of the fluid comes out through the nicks in the conjunctiva. And now we are going to implant the intraocular lens. This is a lens from Rayner. Here goes the leading haptic, and the trailing haptic is placed in the bag by the left hand instrument. Now you can see the anterior capsular rim is overlapping the optic of the intraocular lens all around, which means the size of the rhexis is less than 6 millimeter, and it is nicely centered. I am irrigating some BSs through the main wound. I go behind the lens and irrigate some more fluid, and then I aspirate some fluid, and most of the visco has come out. But I don't stop here. Once I put visco, I spend about a minute or two to clean the visco. I go with irrigation aspiration, irrigation through main wound, aspiration through the side port, and do irrigate and aspirate. See, to maintain the antechamber depth, I am lifting the anterior wall of the main wound, and the chamber is always deep, and this cone is never touched by this technique. So in this video we have seen three things. Number one, Subtenon block. Number two, use of Phenocaine to dilate the pupil for those patients where we cannot put drops. And then we have seen use of a nucleus cutter or Prechopper with the help of a nucleus sustainer, and that reduces the ultrasonic energy a lot. this is closure of the side port, and now we are at the end of the surgery. I always do a final lavage with PSS, and I want to leave clear fluid without any particle, and I want to ensure that there is no leakage of fluid at the end of the surgery. I take cotton Johnson bud, and then I check if the wounds are nicely sealed or not. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.